Hello and welcome to Living Sickle Smart. I am your host, Ray Blaylock with Sickle Cell Foundation of Minnesota. And today we have such an intriguing topic. Not only is it intriguing, but it is critically important. We're going to talk with Partnership to Improve Patient Care. We have the executive director and the deputy director with us today. But first, I want to say special thank you to our partners and sponsors. As I've already said, PIPC, or Partnership to Improve Patient Care, as well as Beam Therapeutics, Memorial Blood Centers, and we always like to recognize the SCDC, or the Sickle Cell Data Collection Program, right here in our state of Minnesota. We are so very, very, very excited about all of the programs that we have happening here in Minnesota around the sickle cell community and around improving care, because that's what we are here for, that's what we work hard for, that's what we fight for and advocate for. But today, I want to make sure that you know you are in the right place. Today, as I said, we are going to be talking about value assessments and QALYs with Partnership to Improve Patient Care. There's so much that we have to learn. There's so much that we need to know. And by knowing this, we can step up in the ways that we advocate. We can address some of these issues from a place of knowledge, not a place of, I heard this or I think that, but we have to know what's going on so that we know how to show up. So without further ado, I'm going to stop sharing here. And I want to introduce you to our wonderful, wonderful guests. First and foremost, I want people to understand what Partnership to Improve Patient Care is all about. This organization was established to advance principles of patient-centeredness in an evolving health system. PIPC advocates for the voices of patients and people with disabilities to drive the research that forms the infrastructure for meaningful shared decision-making and improved healthcare decision-making. Ultimately, their goal is to ensure that value in healthcare is defined as achieving outcomes that matter to patients. So I will begin with introducing you all, as I said earlier, to the executive director and deputy director. First and foremost is Sara van Geertruyden, and she is the executive director of Partnership to Improve Patient Care, which is also chaired by former Congressman Tony. Pronounce that for me.
Quello.
Solo.
Quello. So
Quello.
Quello. Yeah.
Quello. I love it. Original author of the Americans with Disabilities Act. That's a big deal. Sara joined PIPC in January of 2011 and also serves as partner at the firm Thorn Run Partners. Her work is focused on policies to advance a patient-centered health system, from patient engagement and research to driving outcomes that matter to patients in healthcare payment and delivery. She is a healthcare and welfare policy expert with over 25 years of experience, y'all. She began her career on Capitol Hill working for former Senator John Breaux in Louisiana from 1996 to 2003. Then as an attorney at the law firm Patton Boggs, where she practiced in the public policy group, handling regulatory and legislative issues related to healthcare, welfare, and appropriations for clients. Now, Sara's currently also serving on the board of directors for the Center for Adoption Support and Education, where she provides pro bono government relations counsel. My, that is a power-packed bio. But let's also talk about Ms. Thayer Roberts, because Ms. Thayer Roberts joined PIPC as its deputy director in March of 2019. And in that role, she works with PIPC's diverse membership of patients, healthcare providers, researchers, and other groups to ensure that patient centricity is at the center of our nation's healthcare system. Now, prior to joining PIPC, Ms. Thayer served as the Senior Director of Alliance Development at Research America, where she worked closely with the organization's membership of patient advocacy organizations, academia, scientific societies, and industry to convene appropriate parties and to develop programs to advocate for a policy and regulatory climate that supports medical innovation. Ms. Thayer received her BA from Boston College. Wow. I am thrilled and I am humbled to be sitting here with you all. There's so much for us to learn about what you do and how you do it and how it affects all communities, but particularly how what we in the sickle cell community can gain knowledge in and show up for in our advocacy roles. So I'm going to turn this over to you, Sara, and we'll get right in to this session.
Thank you. I'm going to share my slides too, so that we can get started. But I really appreciate you having us join. It's a complicated issue that we're going to be talking about today, but at the same time, I think it's just so important. And we're really excited to get started. So Thayer and I have been doing this for a while. I was really excited to have Thayer join us a few years ago because, we got, as PIPC started to grow in our scope, a lot of the issues that we were formerly dealing with were mainly federal in scope. And then over the last few years, we've really extended our focus to the states where a lot of these issues are percolating. So between the two of us, it's given us a lot more bandwidth to be able to address some of these issues that we're going to talk about today. So we're really pleased to be here, and please know that you can have access to both of us, and anytime you have questions, please reach out, because we know that this particular issue around the QALY, it involves a little bit of math and it can get a little complicated. So we're going to do our best to explain. So just a little bit about PIPC. As Ray mentioned, Tony Coelho, who was a former congressman from California, also a patient with epilepsy, is the co-chair of PIPC. And when he started this coalition, it was in the early years of, you might remember, around 2007, 2008, comparative clinical effectiveness research was sort of a hot topic on Capitol Hill. And from that debate, an entity called the Patient-Centered Outcomes Research Institute was created. Our coalition really pushed for the creation of that entity to do research that was centered on the needs of patients and people with disabilities. But not just in terms of, token engagement, right? The goal was to make sure that they had a vote on the board, which they do. There are 3 seats on the board for patients and consumers. And we've really taken that messaging and that goal to everything that we do. Patients and people with disabilities should always be at the center and should always be at the table, not just with a voice, but also with a vote where possible. So we really pride ourselves on bringing that perspective to the policy debate. But today we're here to talk mainly about a thing called quality adjusted life years. So quality adjusted life years are a metric that is used to determine the value of treatments. Now, to calculate a QALY, you have to give value to, you have to assign a value to a person's life. And then now when you assign a value to a person's life, so let's say you have a treatment that is focused on treating older adults or people with chronic illnesses or disabilities, because the value that will be assigned to living in that state will be often lower than that of a younger or healthier person. So then when you calculate the value of extending the life of a person, right, you will find that treatments that are specifically tailored for those populations is lower. Now that can lead then to a discriminatory outcome in terms of then how that treatment gets valued because of the devaluation that happens of those lives and the value of their life extension. So that often then unfortunately leads, for where policymakers and payers rely on those metrics, you find that those treatments often they're either not covered or sometimes they may be just covered, but covered with hefty prior authorization or other utilization management strategies that prevent people from easily getting access to care. And so when you see this chart, we like this chart because it sort of puts the numbers in a more understandable way. You see moderate multiple sclerosis is an interesting example where the value given to the life of a person living with that condition is 0.5, so half of a person who's young and healthy. You often sometimes can find too, though, with certain conditions that they will assign a value that is quote unquote worse than death. right? So ALS is an example of that, where there are quality scores out there where the calculation would say that it's worse than death to be living in this state, which, as you can imagine, for people who live in these states, they would heavily disagree. Slide forward. So just to get into the more specifics of the QALY, some of the problems include that under the QALY, extending disabled life is worth less than extending non-disabled life, which the prior slide, I think, does a good job of showing. The second problem is the process of translating clinical outcomes into the utility scores results in a loss of information. So, for instance, when a survey may be done of people living with a condition, they might ask if your disease or condition is mild, moderate, or severe. Well, most people don't describe their condition in those terms, and there's a lot of information that's lost when you just say, is your condition mild, moderate, or severe versus are you able to sit up? Are you able to walk to the store? Are you able to take care of your kids? Some, more nuanced sort of information that might provide more information. Also, people with disabilities may attach different values to their own health states than the general public. There are a lot of studies that have been done on this now. There was a great one that Ari Naiman did in a health affairs blog actually recently, where they looked at the public's perceptions of people who live in certain states and people who have disabilities, certain health states and people with disabilities. And it demonstrated that actually the general public has a bias against people with disabilities. So when you ask people, should we take care of people who are healthy versus people with disabilities first, a lot of people in the general public will say we should be taking care of healthy people first. Also, quality-based value assessments are unlikely to account for clinical knowledge on patient variation that's not yet in the research literature, which anyone who's lived with a serious condition knows that their doctor, because they are experiencing the outcomes for patients on various treatments firsthand and personally, they often can say, wow, I think for you this will work, or for you that will work, just based on what they know about the characteristics of their patients. And oftentimes that kind of information takes a really long time to get into the research literature. It's not known, and yet there's a lot of that lost information is not reflected in value assessments. So I wanted to, this is a new slide for us, talking a little bit about the math bias and value assessment. And I think this is important because we've been talking a lot in various audiences about the algorithms that are used to determine whether or not somebody gets care and treatment. So for instance, in California, actually, the Attorney General has put out a request to hospitals to better understand how hospitals make decisions about the care that they provide, because there is an understanding that there are algorithms that are being used in healthcare. And this is also reflected in some of the proposed rulemaking happening at the federal level, that there's an effort to try to better understand where these algorithms are being used. And, you hear sometimes about how AI is biased, right? We're trying to better understand how these algorithms then lead to discriminatory decision-making in healthcare. So specific to what we're talking about today, though, with the quality adjusted life year, it is a math bias, similar to what we talk about in these broader algorithm discussions. So for instance, life expectancy estimates may present a biased view of life years gained. If you create a weight that goes into the calculation that's based on an older population or from a population that has coexisting conditions or disabilities, then you're going to find that there's a skew there in terms of what those weights look like. Why? Because an older population will have fewer life years left. And if people have coexisting conditions or disabilities, you might have a shorter life expectancy. Also, the quality of life calculated from these biased surveys will be skewed based on the public perceptions that I was talking about earlier. So the source data for the weights that turn life years into quality adjusted life years may come from populations that are either unfamiliar with the condition or that have a bias against living in the described health states. So interestingly, historically, the United States has worked against the use of QALYs. That being said, I think, it's troubling that we went from 1990, the Americans with Disabilities Act was passed. 2 years later, you have a situation where Oregon proposes to use QALYs to develop their prioritized list of services, but the administration said, no, you can't do that because that's a violation of the ADA. And then many years later, when the Affordable Care Act was being passed, there was a QALY ban included that applied both to PCORI, the Patient-Centered Outcomes Research Institute, as well as Medicare, which prevented the use of these kinds of cost-effectiveness assessments using QALYs for making coverage and payment decisions. But since 2010, and we'll talk a little bit about this going forward, entities have emerged that are increasingly using QALYs to value treatments, and those assessments are increasingly being used by policymakers and payers. So in 2019, the National Council on Disability responded to this by recommending that federal programs not rely on quality adjusted life years and those kinds of cost effectiveness analyses because they are contrary to U.S. civil rights and disability policy. And then a few years later, the Inflation Reduction Act responded to that by barring the use of comparative clinical effectiveness research that treats extending the life of the way that they say it in the statute is extending the life of an elderly, disabled, or terminally ill individual as of lower value. And we're watching that implementation closely. That applies to the drug negotiation provisions that were in the bill. So we went from in the 90s, I think we all thought QALYs were sort of going away. But yet here we are where we actually are seeing an increased use of QALYs. So in response to that as well, President Biden in his campaign statement said that he would ensure that people with disabilities are not denied coverage based on the use of quality adjusted life years. And he says, and related enterprises in making coverage and payment determinations in public programs. And then you have the DNC platform, which states opposition to the use of QALYs. And last year, Republicans introduced HR 485, the Protecting Healthcare for All Patients Act, to extend the Medicare QALY ban to other programs. So we have a lot of bipartisan concern around this metric that we hope Congress will act on. But in the meantime, we're certainly wanting to stay vigilant about how states are increasingly using the metric. Now, the reference point for use of this metric is often coming from an entity called the Institute for Clinical and Economic Review. This is a private research organization that conducts these kinds of quality-based cost-effectiveness assessments of new treatments. Typically, it's a treatment that's coming to market that is pending approval with the FDA. They have what's called ICER Analytics, which is a website that is sort of a subscriber-based platform that payers and states, so think about your P&T committees, pharmaceutical and treatment committees that determine what access to drugs looks like in a Medicaid program, right? These entities can subscribe to ICER Analytics and use those analytics then to make judgments about a treatment's value and look at their policy recommendations, such as, did they recommend prior authorization for this particular drug? And that, of course, then has implications for how patients access those products. So some of the concerns about ICER's analyses include their reliance on QALYs, which has been the subject of a lot of consternation, particularly among the disability community. Its failure to meaningfully engage expert stakeholders. I think ICER over the last few years with a lot of pressure has been increasingly engaging, but then I think the question and the concern is the extent to which that engagement translates into their final product and the recommendations that they make. And that's where the disconnect happens and people get very concerned. There's also a failure to consider outcomes that matter to patients and people with disabilities. So a lot of times patient groups will very robustly engage in an ICER process to value a treatment. And then they'll find at the end that the outcomes that they communicated were really important to them and they thought should be measured weren't measured. The other big concern is that these assessments are premature in the sense that they're coming either before or right at FDA approval typically. So there's not real world evidence about the products at the time that ICER is conducting the assessment. Instead, they're making a lot of judgments based on very limited clinical trial data. As you know, diversity in clinical trials is tremendously lacking. So the impact that a treatment may have on subpopulations that are not represented in the data gets lost, right? So if a treatment has a differential impact among those subpopulations, it's probably not going to get captured. There's also a lack of transparency to people who are living with those study conditions in terms of how they got to the cost effectiveness number. When ICER says at the end of a study, we think that this drug is worth X and that these people should access it versus others, it's not really clear how they come to those conclusions. It's not a peer-reviewed process, so it's not replicable. So now what happens in states that we all look out for is how they then use these cost effectiveness studies and value. And so with tight budgets, you'll see states looking for one-size-fits-all solutions to reduce their healthcare costs, unintentionally embedding discrimination. So there's a group called the National Association for State Health Policy. We call it NASHP. They have template legislation that they then sort of shop to various state legislatures. And a lot of that template legislation seeks to increase the use of metrics such as through ICER studies to help states then make decisions about what they will reimburse and cover in response to costs, right? So states trying to reduce costs by then looking at ICER studies and finding ways to be more restrictive with their formularies. Now, Oklahoma, it provides us with a little bit of a different model. They actually passed a statewide quality ban back in 2020, which addressed some concerns that they had around their drug utilization review board, which was using QALYs to restrict access to treatments such as for hereditary angioedema and spinal muscular atrophy. Minnesota just recently passed its own legislation, which creates upper payment limits. And I think a lot of the concerns that have been expressed around the Minnesota legislation that just passed is whether or not they will reference whether they will reference QALYs or reference these ICER studies. So that's just something for you to look out for. So generally speaking, the way that we see this legislation emerging is through the creation of what's called a prescription drug affordability board. In Minnesota, the way that the legislation was passed, it did not create a quote unquote board, but it did create a process for doing what a board does, which is to create upper payment limits for prescription drugs. A lot of these bills permit states to rely on third-party research or contract directly with a third party to define affordability and upper payment limits for those chosen products. We see in New York and in Massachusetts that they specifically rely on ICER's value assessments. So that's just something that as advocates, you probably want to watch with this process, how this process unfolds in Minnesota with the implementation of this new legislation. And then states like Oregon and Minnesota have passed actually safeguards to preclude a prescription drug affordability board from using the QALY or partnering with third parties who use the QALY or similar measures to determine affordability and payment limits. The legislation that was passed in Minnesota did address the QALY, although it's still unclear. It's unclear to me, and I think this is why it's really important to follow the legislation, the extent to which it will fully bar reference to entities like ICER. So I think that's just something to keep an eye out for. And as the state moves forward, if they do go in the direction of creating a full-blown Prescription Drug Affordability Board, I think it's important to note that you want to make sure that the quality band applies both to the affordability determination and the payment limit determination, because in some states they've done a quality band for the payment limit determination, but not the upper payment limit determination, or vice versa. So recent state bills also will reference the Medicare maximum fair price where available. And so this is a methodology for determining prices in Medicare. That was the reference that I made earlier to the Inflation Reduction Act. That process is still sort of unknown, and we're not clear whether or not it's going to be a process that does or does not use QALYs. There is some language that advocates would argue bars that process from using QALYs. But it's certainly something that everybody's watching closely because it's still an unknown. So to the extent that Minnesota seeks to reference those prices, we would argue that you should be just vigilant and watching and making sure that it's that it doesn't play out in a manner that's discriminatory. So anytime you're looking at your state-based processes, we would highly recommend paying attention to some of these buzzwords and ideas. So in some states, we've seen reference to Canadian prices, which are absolutely based on QALYs. It's been a very controversial thing in Canada too, because of the restricted access that a lot of people with disabilities have as a result of them relying so heavily on QALYs to determine what they will cover and in what circumstances they will cover it. So we saw the National Council on Disability, as part of their report, actually recommending that the United States should not reference prices in other countries that rely on QALYs. So just something to keep an eye out for. Also, whenever you see provisions that allow for reference to third parties, that's another area that is very concerning, because oftentimes that third party is ICER or a similar entity that's conducting QALY-based value assessments. And you want to make sure that the value assessments that are being referenced, if there is authorization to look at effectiveness analyses, we don't want those to be QALY based or based on measures that are similar to QALYs. The equal value of life year gained is a metric that you may hear come up. It is a kind of a side-by-side metric that ICER, the Institute for Clinical and Economic Review, uses alongside a QALY. It actually relies on the same sort of flawed surveys and the biased math that we described earlier, in terms of, and how they determine whether a treatment is effective. It's called an equal value of life year gain because when you look at the life extension, what they do is they give everybody a 1, essentially. But then they don't have a calculation for looking at quality of life improvement. So it really kind of skews then towards valuing treatments that extend life, but if it's a treatment that just improves quality of life, so say this is a product that will make you feel better, but it's not necessarily going to extend your life, it doesn't do a good job of capturing that value. So there's still a lot of concerns around this equal value life year gained. And then with engagement, I think one thing that we've consistently advocated and talked about is that whatever process states are using to look at the value proposition, there should be patients and people with disabilities at the table with a voice and a vote. And that is, I think the vote part, it's easy to talk about a voice, but unfortunately that sometimes leads to what we would call token engagement. And you really want to make sure that you've got patients at the table with a vote and determining whether you're looking at affordability questions or payment limits, and certainly coverage. You always want to make sure that patients are at the center. So now we have some template legislation that I think is really interesting. It's on www.valueourhealth.org, and I'll share those links at the end. But the template legislation that these Value Our Health groups created provides a sort of a response to the NASHP template legislation that would invite the use of QALYs. Instead, it creates standards for patient-centeredness and research and analysis. It calls for engagement of patients and people with disabilities and more transparency to the process. Prohibits reliance on discriminatory measures like QALYs, and requires an appeals and physician override mechanism, which is often lacking from these provisions. So that's similar to what the QALY ban looked like in Oklahoma. There's similar QALY ban legislation that's been advanced in Oregon. It has not passed yet, but Oregon advocates are working very hard on it. But I think, until there's a more federal QALY ban, certainly one strategy for advocates in the various states is to try to get a statewide QALY ban done similar to Oklahoma using these types of provisions. And so in closing, I really appreciate the opportunity to be here. Minnesota is, you've got a lot to look forward to. I think you have a process now that's passed the legislature for looking at affordability and looking at drug costs. And in that process, we certainly hope that there will be vigilant monitoring of how that process goes, making sure that QALYs are not incorporated, but also being on the lookout for future legislation that looks at these issues and future processes that may inject or incorporate the use of quality adjusted life years and similar measures into the process. With the goal being, of course, protecting patients and their access to care. So thank you very much. And I hope that this was helpful.
So my goodness, Sara, this is incredibly, incredibly helpful. Let's see, let's stop sharing and let's chat about this because, I want to give a shout out to sicklecells in the sickle cell community, because if it weren't for sicklecells, many of these terms, many of this work that's happening behind the scenes, favorable and unfavorable, the sickle cell community specifically would not be aware of. And I would argue that many communities are simply not aware of this because of the lingo. There's different lingo, and it's happening in pockets, and it's happening, in silos, and, there's a lack of representation, so that there is no transparency that brings it back to the communities that are affected the most. So while we're talking specifically about the sickle cell community, it's not beyond me that we're really talking about this broader community of individuals who with healthcare conditions that create disabilities in their lives, and therefore their quality of life is affected. So so much of what you said, I think the first thing that jumped out at me is your very first a graphic that showed different conditions with the number of life years. And you made a statement that said that there are conditions that are rated as worse than death to live with that condition. I think about friends, family, I think about colleagues, I think about people that are in this space that I've been in for almost 20 years, and to have someone else tell them that their life is less than living because of their disability. The inhumanity of that is mind-boggling, that in a country such as this, that there are those who will speak for these communities and have never lived a day in their lives, have never, in many, if not most cases, have never even spoken with someone who can reflect upon their own quality of life, even with that diagnosis. So yes, we need a voice, and yes, we need a vote, but where is the representation in the decision makers and at the table when they're having these discussions and making those final decisions? What does that board consist of?
So, I think this is where it gets very complicated, because a lot of the utilities that go into the math, like the math part of it, is based on survey data. right? So like you said, like a person maybe answering that survey that has no idea what this condition is, have
Absolutely.
no idea what it's like to live with this condition. And yet there's a researcher asking them, how would you rate the quality of your life if you lived in these various health states? And that doesn't take into account, there's an academic term called hedonic adaptation, which is what that basically means is that you adapt to, a person who is blind adapts to being blind, right? So you're not capturing that adaptation that somebody will still view their life as a high quality of life, even if they're living with in a certain health state that somebody who doesn't live in that health state might look at it from the outside and be like, oh, I couldn't do that, but
and it doesn't mean you want to continue. It doesn't mean you want to continue, living it, but it does mean that you have found value in life.
Of course. Of course. I mean, and there's no attributing and that's it. So it gets very complicated with the math, right? That that value and that quality of life that somebody has adapted to living in and with is just not reflected because it's coming from populations that just don't understand that condition. They don't understand that health state. So I hear you. And that's why we would argue that on a board, in a process where decisions are being made, whether it's at the P&T committee level, in a drug utilization review board, or in any other process where they're making decisions about the value of treatments and whether they should be covered and how they should be covered. It's vital, not just to have a voice, but a vote. I mean, and I know that's in some cases, we often see, and ICER is a good example. So when they actually have their own assessment process, they exclude from the voting committee any patients who live with the condition or any clinicians that treat the condition because they think that they're biased. And instead they have a bunch of people sitting on those voting committees that are not, that
makes sense, right?
That know the least about it. I know.
Exactly.
It doesn't make any sense, but,
that
that really bothers us,
Well, and that is my next question then, because it begs the question, I learned very early in my career, follow the money, right? So who's funding these? Because I find it very interesting that the government who, and I'm not an anti-government person. I think that the government is in place. The ultimate goal is to protect its people. And it's through lots of different perspectives that people see what that, define that. But I recognize that we don't have enough funding coming in through government to do all that maybe they either want to do or should be doing. But then you have these other, companies that are created as a response to what the government isn't doing and saying, hey, since you don't have the money to do this, or since we don't think you should be doing it, here, we'll come in and we'll do it.
Yeah.
And then you'll take what we say as gospel truth, right? And you'll apply that to the decisions that you make. And I think that's where it becomes challenging, because while many of us exist as independent organizations and companies and all of these pieces, being able to make sure that that there is an equitable approach, that there is a fair approach, and that those who you are partnering with, and as you said, when they have external entities that they are hiring to do this work, it's really how do we ensure that those organizations are held accountable, right, to that representation. And I think that's part of the struggle. And that's where I really want all communities, and particularly communities of color and disadvantaged communities, who we know that their capacity to even be able to show up in these spaces is on top of, the level of underserved needs that they have. On top of all of that, then they have to show up and they need to advocate, which is absolutely important. But how do we How do we do that in a way that people make sure that they are part of this process? Because they won't be held accountable until those who are impacted the most speak up, because that squeaky wheel gets the grease. How do we do that in a way that helps them to understand how critically important this is? Because my community, we're all tired of surveys. Nobody really wants to take a survey. And if you do, you kind of fly through it. How do we get people more engaged in order to help to make a statement, make a difference, and to kind of shift the direction that we're going in?
Well, so I will I'm glad you mentioned SickleSMART, because when ICER was doing their assessment, they did do a survey. And I do think that survey was useful to the ICER process. It was disappointing that it didn't translate into the final recommendations in terms of the cost effectiveness analysis. It was referenced in sort of their contextual considerations, though. And I do think it was, from an educational standpoint, it was very useful. So, I mean, we're all tired of surveys, but I do think that, like, in the context of what happened with ICER and SickleSMART doing the survey, it was important to respond to that survey.
Yeah, but that's also because they engaged the community, right? Community trusted community. And because SickleSMART led that charge, that level of trust that was needed to say, hey, this is something that's important, and let me explain why this is important. And now we need you to participate, right? It's not just pushing it out there and saying, hey, if you get some time, complete this survey for us and send it back, and we'll give you, a $10 gift card, right? It's again, it goes back to that transparency and understanding the value of and the why we're doing that.
But I think insisting on the transparency was going to be my second point, because I've answered this question for CMS recently when I was talking to them about the use of qualities in Medicaid, and further prodding, I was trying to explain to them, like, the problem is, so you look at P&T committees that make decisions about what access to drugs look like. Are you going to be subject to prior authorization or step therapy or whatever? When you look at how they make those decisions, it is almost impossible to really understand what evidence they use to make that decision. It might be, and trust me, I've done this research ad nauseum to try to better understand it so that we can make P&T committees more accountable for it. But it often is just like a footnote. There may be a footnote to an ICER study. Well, how was that study used? Did it lead to that decision?
Right? How much?
And a lot of times these P&T committees are also farming out. Their other third parties will be hired to come up with recommendations to a P&T committee, right? And those entities have a proprietary process for how they make those recommendations.
Exactly.
So you have no idea what evidence they used to rely on to say, okay, this is a drug that should be subject to prior auth. This is one that
they have no legal responsibility to share it, because that's how they are trying to show this proprietary process.
So I think that, from an advocate standpoint, and this is hard to do, but it's participating in those P&T committee meetings. Like, especially for sickle cell, if you know that a sickle cell product is on the agenda, right? Be there, be in the room, do the testimony, talk about your experience. But states don't make those P&T committee meet, like they're not
always public. You don't always know when they're happening, or you find out the same day. Like I've testified at DERB meetings, and I'm like, you mean tonight?
Right. That's exactly right. So you really have to be, it's unfortunate, but you have to be on the ball to know when those meetings are happening, and to really go after and look for those opportunities to share your experience. And where there's not enough data to say it, right? I mean, and that's the problem, I think, is that oftentimes you'll hear these entities say, well, we have to make a decision based on something. And when you go, but there is no something, and I'm here telling you about my personal experience, and that's something. I mean, it's very, I just think, that kind of personal testimony, especially in the face of, where clinical trials are not diverse and they don't include certain voices, those voices have to show up somewhere else.
Well, and I want to back up just a little bit so that our audience definitely understands, because any field is full of these acronyms, right, that we use all the time. So I know what they mean, but I want to make sure that our audience does. So P&T.
Pharmaceutical and therapeutic committees, which inform the, so these are the entities that inform payers. So whether Medicaid or private payers, these are the entities that make recommendations around what a formulary looks like.
Okay. And the DRB.
A drug utilization review board has a very similar, a very similar role to a P&T committee. They're making recommendations around what drugs should be covered and how.
Yeah, and as I said, I've testified at both. They're very interesting, and there's not enough patient advocacy in those rooms.
Yeah,
right.
A lot of doctors,
or the doctors, those who have a lived experience, with this population or with this diagnosis is so needed. So another thing that you mentioned is, this research component that they choose to use, and yet so much of that research doesn't make it to the literature. But even more upstream than that is the communities that aren't getting the research that they need, that are not represented anywhere, because there's no funding that's given. Like there's disparities in research funding. We all know that. There's disparities in project funding, and all of those things that actually create this space where people want to kind of be curious and learn more. It doesn't just have to be motivated through the lens of, say, industry or pharmaceutical, but we need to better understand the livelihood of these individuals, of this community, and that lack of doing that. Is this a matter of, I think I heard you speak on it, obviously, there's no federal legislation, and that's why we do so much work on the local level. Where do we even begin on the federal level? Is that how do we best do that so that the trickle down effect, we don't have to duplicate that in multiple states, because now this is standardized federal legislation that all people have to abide by.
My mission in life. Yes. No, it really is. I know that sounds great. So this bill that I described, 485, the Protecting Healthcare for All Patients Act, that bill was introduced to respond to the National Council on Disabilities recommendation that the bar on qualities that exists in Medicare be extended to all federal programs so that it's consistent across programs. Okay. Because right now, there's no, we always thought that 1992 decision related to Oregon meant that states couldn't use qualities, but they are, and there's really no oversight of it because of the lack of transparency at the federal level. So this bill, HR 485, would extend those protections to other federal programs. Now, it has gotten somewhat controversial because I think there are some on, it's interesting how this plays out always, right? You had, when PCORI was created, you had, the far left didn't wanted PCORI to define what was and wasn't covered. Yeah. The way that people thought would, be kind of create an environment where people didn't get access to care. And then on the far right, they were like, oh, we don't want to create cookbook medicine. So, I think we're finding that same debate happening on the quality. There are some on the far left that I think would like to retract some of the protections that were in the Affordable Care Act.
Sure.
And then there's some on the far right that, are sort of like, we don't need to be doing this at all, because it will probably have a score associated with it, a cost.
Well, I'm glad you brought up PCORI though, because, PCORI has really made its presence in healthcare, very valuable. And for those who may not know, PCORI is the patient-centered outcomes reporting. What's the I? Institute?
Patient-Centered Outcomes Research Institute.
Research Institute. Okay, I was close. And I've seen them really take on some really big projects and really create some funding opportunities so that these very nuances can be studied in a patient-centered way. So I want to make sure that I give a big ups to the work that they're doing out there. And how do we ensure that there is more PCORI data that's influencing these decisions? You know, not necessarily all of the ICER and the NASHIP and all of these other entities that really are not authentically engaging with communities, with disabled communities. How do we push that?
Yeah, you know, that's a good question. Yeah, PCORI does have advisory committees, advisory panels. There is a patient engagement advisory panel. I participated in it when it was first created. That they created what's called a patient engagement rubric, which you can imagine when PCORI was created, it was so interesting that what we learned was all these researchers were like, well, we got a letter from this patient group saying they support our research. So we've engaged, and we would be like, no, that's not engagement.
No.
And so we had to create a rubric that essentially provided guidance to researchers on what it meant to genuinely engage patients in the design of a research study, right? Capturing from the patient what outcomes were going to be measured, because, you know, what a researcher would choose to be measured as the outcome of a study wasn't always particularly useful. So I mean, I think participating and there is also a health equity. I think they changed the name from it being a panel focused on disparities to equity, but there's also a panel focused on that a lot of folks. That's been really great for kind of the inclusion piece and making sure that there are recommendations to researchers about getting all the voices in the room. So that panel is, and it also focuses on research prioritization to make sure, because one of PCORI's key principles is, and research priorities is around health equity. And so that particular panel has been very, I think, helpful in driving what their research agenda looks like on the health equity side.
And those are open to the public, so public can apply to be a part of it.
You can apply to participate, yeah. I think they just went through a round, but I would definitely keep an eye on when those opportunities arise, because those are great panels to participate in. And PCORI also has Board of Governors meetings every 2 or 3 months that the public can comment on. So those are opportunities too. If there's a space where you see a lack of funding and a lack of focus, you can take that directly to the board through those opportunities. And PCORI also, I mean, they have what's called engagement awards. I think Sickle has participated in some of their engagement awards where they're smaller dollar. They're not like big research awards, but still like $250,000.
Makes a difference. Absolutely.
And it helps to bring people together to set priorities and to think of, and to help the community engage in research, right? Because, I mean, I think what PCORI has learned is that it doesn't always come naturally for a patient to be at the table and to be engaged in these research projects.
Absolutely.
Right? There's some education that needs to happen so that when you're sitting at a table with a bunch of researchers and doctors and, you know, that you can participate in a meaningful way. And honestly, they need to be educated too around how to appreciate the patient voice that's at the table.
Absolutely right. I oftentimes hear the term, health literacy, and it is typically turned towards the patient, right? And I always argue that health literacy actually impacts everyone at the table. It's a matter of understanding that perspective and how that's communicated to back and forth, right? That chain of communication. So health literacy is something that we all seek to better understand, but we have to use the same language, and we don't all use the same language, right? So, I could go ad nauseum talk about health literacy, my issues with that terminology, but,
that is exactly why that patient engagement rubric was created, the compensation rubric, right? Because who has the resources to just go and sit in these,
exactly.
You have to treat your engaged patients as the experts, and
That's
other
right.
experts at the table are getting paid. So why aren't we
That's right.
compensating the patients who are participating and providing their expertise as well?
Yeah, and most of the time, those researchers, like they are in their role, in their job, they are showing up for work, and their work
Right.
is to do the research. Whereas you're asking patients to actually take a day off of work if they're able to be employed.
Exactly.
You're asking them to take a day out of their busy schedule. You're asking them to impact. Yes, they are impacting their quality of life by showing up, but they're also impacting their quality of life in what they're not able to do because you just told me 3 hours ago I need to be, I need to speak at this DERB meeting, and there's a lack of understanding what each of us need in order to be able to show up to talk about our lived experience and our story, and then making sure that the community recognizes, because this is something that's really important to me. I've been in the healthcare space for almost 20 years, and it took me many, many, many years to even begin to realize that there was more advocacy groups available and around that are doing, things, even rather small or large, that most of us know nothing about. Right. And so it's also recognizing that we are a resource group. Yes, we represent at Sickle Cell Foundation of Minnesota, we represent our warriors in Minnesota, but we also have a national and global footprint because this condition doesn't just affect people in Minnesota. So it's making sure that we are interconnected somehow so that we strengthen our voices as one bigger community. I think about the rare disease community, right? The rare disease community has really come a long way in saying, this is not about any one particular rare condition. This is not about which rare condition is most common or least common, but this is about this entire community. And how do we make sure that this community is not lost? And we'll talk about the nuances of each diagnoses, but we have to make sure that the community at large is not lost. And that's the way that I see the work that you all do. That partnership piece is so important because it takes partnership. None of us can do this alone. None of us. And we are stronger together than as one. So we appreciate all that you're doing. But I want to tie this up with talking about legislation. And because frankly, I came to a place in my career that I used to talk to a lot of people and I wanted people to change it. And I still do, don't get me wrong, but I am extra committed to making sure policy changes, right? Because when people move positions, when people, change their minds, or when people matriculate out of roles, you have to start over every time. and that's exhausting, but it's also not a great use of resources. So this policy, legislation, being able to make a difference at the policy level. I love that Minnesota, and that's how we came to know one another, right? Because Minnesota was going through some of these legislative loopholes, I should say, loops that we have to jump through.
You did a good job. You got a quality ban in that bill.
Exactly. We worked pretty hard to make that happen, but I want people to know, you said something, I want to reiterate what you said. We also need to make sure that there's accountability within that legislation. We need to make sure that which the legislation was intended to promise, or so we were led to believe it's intended to promise, that they fulfill that promise. And not just in the beginning, but throughout every process. And if we need to create more legislation just to insulate that promise, then that's what needs to be done.
And that's why I wanted to raise that template bill, because I do think you've got a quality ban bill that is supposed to be informing the process for how they look at affordability and pricing and access to drugs. But at the same time, it is not clear, because of what we're seeing happening in the academic community is that they'll say, oh, we're not using QALYs, but what they are using is similar to a QALY in the sense that it still has that bias in what we call the health utilities. Just call it the math, right? Yeah. The math is still based on the biased surveys, the biased perspectives around quality of life. And you have to look at the integrity of the metrics that are going into determining the cost effectiveness analyses. And I guess our fear is that in transitioning from equality to something else, that the underlying math isn't going to get fixed.
Exactly.
And so that's why I think we still want to be very careful that whatever comes in its place, right? Because like the equal value life year gained is a metric that some people have mentioned as being a replacement for the QALY, and it was never intended to be a metric used out. It was supposed to always meant to go alongside a QALY, right, as a kind of a qualifying metric. But B, it's got the same math bias inherent.
Absolutely. And one just reflects the other, and
right.
Typically they don't go against their findings with one another. And, and that was kind of when I heard you say that, because and I think I wrote it down, the equal value of life years gained. Even if you don't gain life years, you want the quality of the life you do have.
Right. And that's the bias of that.
Appropriately. You want there to be some attention given to if my child, and gosh, my heart goes out to it, because there are children, there are parents who gave birth to children that they knew that they would not make it into adulthood, but they wanted the years that they did have them to be meaningful, not just for themselves, but for that child. And the lack of being able to see the value in that piece, this has to be a bipartisan issue. Health is a bipartisan issue, right? There's no partisanship in that. It has to be, a non-class issue. It has to be a non-racial ethnicity issue. It has to be a human issue. And that's where, it boggles my mind that that's what we're arguing over and that's what we're advocating for. But the reality is the reality. And so knowing that, my ask to everyone, whether you consider yourself in the rare disease community, whether you see yourself in the disability community, the fact that we want every life to matter, the fact that no one gets to decide for you what conditions are worse than death to live with. No one gets to decide that for you. And the value of your voice, the value of your story, the value of your lived experience. I'll be the first to say the wheels of change move incredibly slow. Much slower than I would like for them to, but they don't move at all if we don't show up and we don't represent and we don't use our voice. And so, what PIPC does is incredible. But in this moment, the education to communities who just simply don't know is invaluable to help us to know how best to show up when there are bills. I love templates. So anything I shouldn't say anything, but when there's a good template out there, I'm like, shouldn't we all be using this? I'm that person that would read, SOP, standard operating procedures, because, to better understand where we should all be centered around. And then we build it out from there. We're not saying this is, from A to Z, but we're saying this is a skeleton that says, start here and build from there, is really valuable. So do you think that, or I should say, does PIPC have, or are they thinking about creating toolboxes of templates for communities to be able to write letters and join those campaign efforts to make changes locally?
So we do have, we have the template legislation that I described, but then we also have a template letter that walks through the disability and civil rights history. Because we would argue, and National Council on Disability, whose job it is, they're an independent federal agency that advises Congress on disability issues. And they made the point too, that these non-discrimination provisions that are in the Affordable Care Act from Section 504 of the Rehab Act, when you add all of that up, they would argue that QALYs are against the law, like they are
Absolutely.
contrary to the law, because but again, it takes that level of transparency and oversight to get there. And so there is some effort at the federal level through rulemaking. The last 1557 rule actually asked for comments on this issue, which we were really excited to see because it means it's on the federal government's radar.
And comments mean the general public, was it specific to non-general public?
It was general public. So they asked for
Excellent.
comments because there will be a revision at some point in the future of the 1557 non-discrimination provisions.
Okay.
They
So
haven't
those comment
finalized
periods,
anything yet.
and I circled back to that because I want people to know how important the comment periods are as well. When the general public can give their opinions, you may not, it's another way of testifying, right?
That's exactly right. And there's an upcoming, we're waiting to see what's going to happen with what's called the Section 504 of the Rehab Act. There's been allusions at the federal level that they're going to come out with a proposed rule to amend those regulations as well, which would provide potentially another comment opportunity here. So we'll happily share that with you when it happens, because
Fantastic.
I do think it would be, I think it's really important that state-based advocates be engaged, because there is a federal protection in Medicare against the use of QALYs. There is not one in Medicaid.
So Medicare, but not Medicaid.
Right.
That's
right. So, I mean, that's why these states are getting away with using QALYs, is because there is no well-defined consensus around what the law is here. And that's why the federal legislation exists, is to take that Medicare QALY ban and try to extend it in a consistent way across, so that whether you're a CHIP program or a Medicaid program, that these payers, whether it's whatever entity is making the decisions, that QALYs cannot be part of those decisions.
Well, one of the things that we want to do, we want to commit to creating space on our own website that explains what this is in layperson's language, but also provides that access to resources of how to join this advocacy effort, because it doesn't just stop. It's not a one-stop shop. It's something that we'll have to continue doing, and it's something that we do for our state, but it's also something that we need to understand. How do we show up for other states to make sure that where one state begins to get it right, how do we continue to duplicate that from state to state as we work to make these things a federal legislation. And so we are incredibly grateful. I feel like this is just like part one of like 17. Like there's a lot to learn. And before y'all email me, I'm learning myself. I'm certainly trying to better understand what advocacy looks like in these spaces. A bill doesn't have to just say sickle cell disease or just say one condition for us to show up or to read the bill to better understand how it impacts broadly, because all too often that's what happens and everything else just gets swept in. And you may not see that on the front end. And so we do have to be part of this, of legislation. We do have to be part of even the voting process to make sure, are we putting people in office that represent our interests? It's more than just what the media says, but sometimes we have to read, we have to do our own research to better understand where they stand on particular issues that either align or don't align with your values and your needs, as personally and in your community. And so we have to continue to be vigilant in that way. This has been incredible. There's so many questions that I have that I won't ask on air because this is a work in progress. And I want all communities to be represented. I want us to better understand how we are impacted, how we can make a difference. My last question, because I know that I'm going to get an email, is how do we know if you have a particular condition where you might fall on the QALY as is being seen or measured currently?
So there's a measurement called the EQ5D that informs the QALY, and an ICER will, sometimes they'll use the traditional EQ5Ds, and sometimes they'll use more other ones. But I would say that's sort of where to start. But yeah, I have to go back and look at the ICER, what they used in their last report, because
Okay. So they
but I
are
think
out
it was
there.
somewhere in the neighborhood of it was somewhere I think it was similar to where MS was, but I have to go back and look.
Okay. And so as we continue to create resources and information through our own platforms, that'll be something, those types of things that people can access to better understand how it personally affects them, and then how they can use that to then show up to advocate for this broader disability community, which we are all a part of. And so thank you so very much. As we talked about, making your voice matter. We talked about being part of attending like governance meetings. We talked about being part of review processes. All of these pieces are ways that we can be a part of change. And sometimes I find that people want to be a part of change, but they just don't know where to begin. And our goal is to simplify and to give you just a few small things that you can do now as we grow into these bigger ways that we can show up. And you have the experts like PIPC who have an incredible organization of individuals who have been in this space for a while and can help the rest of us navigate how to do that. So we appreciate all that you do. I want to make sure that I let's bring Thayer back on. Thayer, if you're still there, you are ready. I love it. You're on mute. Anything that you would like to add?
No, I think Sara summed it up really well. What I would say is just that these issues get really complicated, and we know that. So we're always available for questions, for chats. If anyone's interested in learning more about this, please don't hesitate to reach out. We're always happy to have those conversations.
That's fantastic. You said that it's almost as if I gave you a script. I want to make sure people can reach you all if they have questions as well. So I'm sharing my screen now. Of course, as I said before, thank you so much to both Sara and Thayer for being on the show today. PIPC, again, partnership to improve patient care. They can be reached on Facebook, on Twitter, and on LinkedIn. You'll see on the screen now on Facebook at Partnership to Improve Patient Care, all one word, even though I see a space in there, it still is only one word. Twitter is going to be at PIPC Patients, again, all one word, and on LinkedIn as PIPC Patients. So I encourage you, dig in, do some homework, learn what this is all about, because it does make a difference. Before we go, I also want to remind people that they can view future SickleSMART sessions through our website. You can learn more about our SickleSMART education program. But if you want to know when we are going to have new shows, you can also follow us and sign up to follow us through Eventbrite at bit.ly sicklecellmn-eventbrite, and you can be notified whenever we post new opportunities to join us on our live shows. You're watching a pre-recorded, but we always have live shows as well. Also follow us on social media. We too are on LinkedIn, we're on Facebook, we're on YouTube, Twitter, Instagram. Yes, we even have a TikTok page. So we're getting there. But you will find us at SickleCellMN, again, at SickleCellMN, all one word. If you go to our YouTube page, you will actually find that we have an education repository full of lots of different videos of different topics that affect the living well with sickle cell. So we invite you to join us. I think we're up to 60 or 70 videos at this point. The goal is to empower you with the information that you need to be a part of your care and to improve where your care trajectory is going. So you can join us at bit.ly /sicklecellmn-YouTube to see that. And Let's see, what do we have next? Our virtual activities are also found on Eventbrite. We have 3 standing events that we do every single month, and that is our Sickle Cell Community-Wide Support Empowerment Group, which happens on the last Thursday of the month. Our Ask Dr. Nelson, which is our SickleSMART Town Hall. We invite you to come join in. You decide the topics, and then we talk about it as a group. And we are very transparent about the issues that don't get enough attention. We talk candidly, we talk openly, but most importantly, we talk honestly. And then more than our sickle cell, it's our monthly community conversations that bring together individuals from all corners of the world, because we are more than just our diagnosis. We are so much more, and we talk about all of those different issues. So we are really glad. We would really love to have you join us. And then if you are local, and depending on when you're watching this video, you can join us for our sickle cell slow roll, which happens at the end of June. And in the future, it happens in the month of June every month, as we honor World Sickle Cell Day. So it's important that you show up. We want to see you there. That's an in-person event. And then we have a race, racism, and health equity that is coming up, and we will be talking with Dr. Nathan Shomalo, who is the Minnesota Medicaid Medical Director. So we're going to have a great conversation there. If you're not able to join us for the live, be sure to look for the recorded video on our YouTube channel a few days after it takes place. That's not till July 25th, just so you know, in case you're coming to look. Last but not least, donating blood. So many conditions need blood, and many conditions rely on blood in order to achieve that quality of life. And some conditions need more than others, diversity of blood donors. So we really encourage you, particularly if you are from a community of color, the Black community specifically, to donate blood. No blood does not have a color, but the more often you are requiring a transfusion, the closer those matches have to be, and those close matches are often found within the same ethnicity groups. And so that's why it matters. Diversity matters. And last but not least, our voices, you hear me say it all the time, our voices do matter. So we want you to tell your story, share your medical experiences. This is not limited to just sickle cell disease. We want to hear from people who interact with the healthcare system. We want to know what's going well as we want to know what's not going well. We want to make sure that when we sit at the table and we are speaking truth to power and we are influencing influencers, that we are utilizing your real live lived experiences in those conversations. We never use your name, but we do use your experiences. So we invite you to be a part of that by sharing your story with us at Our Voices Matter Too, using our bit.ly shortcut. That is it. We want to again say thank you to our partners and sponsors, PIPC, for being part of tonight's show, Beam Therapeutics, Memorial Blood Centers, and the Sickle Cell Data Collection Program right here in Minnesota. So we appreciate that. Sara, Thayer, once again, we say thank you for being part of this session. Such great information. I know we will be following up and having more conversations. So thank you so much.
Thank you, Ray.